Great. Thanks, Anita, for having me. The last time I was here visiting my good friend from undergraduate medical school, Ohio State, won the national championship, so maybe that's a good omen for next year. So these are my relevant disclosures. Over the next 10 or 15 minutes, we're going to go over the management of ulcerative Proctosigmoiditis, which really should not differ much from how we treat patients with extensive or pancolitis. The goals of therapy are the same. We want to induce clinical remission, which we can define as the absence of symptoms. We want to avoid short and long-term toxicity of our therapies. We always want to maintain a steroid-free remission and avoid repeated courses of steroids. If we do these things, we enhance quality of life. We want to prevent and treat complications of disease, so we want to prevent a patient from entering the hospital with megacolon or developing cancer. We're moving towards enhanced endpoints of treatment, such as normalization of biomarkers and achievement of mucosal healing, which is termed deep remission. And in 2019, we want to look at avoidable use of resources, so we want to try to prevent ER visits and hospitalizations. So Marla already went over separating symptoms from prognosis, and we're going to go over that again just so that we all have it. In patients with ulcerative colitis, those that have a more limited anatomic extent, so your ulcerative proctitis and proctosigmoiditis patients are lower risk for colectomy. Those that have milder endoscopic disease are also less likely to undergo colectomy. Your higher risk patients have extensive or pancolitis, deeper ulcers, young age at diagnosis, high inflammatory markers, which tends to predict extensive or pancolitis, and we'll go over that in a minute. Those that require steroids, particularly early on after diagnosis. David Binion always emphasizes that a good way to distinguish a high-risk UC patient is whether they've ever been hospitalized for treatment. That's a good predictor. And then those that have concurrent C. diff and CMV infection are really difficult to treat and at very high risk for colectomy. What's the natural history of proctosigmoiditis? And oftentimes in these, this is a systematic review that doesn't really break it down into proctosigmoiditis. It's usually left-sided or proctitis. But approximately 40% of patients will have left-sided colitis. And the rate of progression from left-sided to more extensive colitis is about 21 to 34%. So the phenotype, the extension can change. Likewise, it can regress as well. Left-sided colitis and proctitis are associated with a decreased risk of hospitalization. And if you look at colectomy rates at 10 years by extent, it's 19% for extensive colitis, 8% for left-sided, and only 5% for proctitis. And the patients with ulcerative proctitis and proctosigmoiditis have little to no increased risk of colorectal cancer, so they do not require more extensive surveillance as opposed to our true left-sided and extensive and pancolitis patients. Despite the excellent prognosis that I just showed you, that does not mean that for proctitis and proctosigmoiditis patients that you should undertreat them. I think a common mistake in the referrals that I see is that patients are continuing on ineffective therapy because the disease just involves the rectum, and that's a mistake. So talking about symptoms, so how do we classify patients based on their symptoms? So typically when we're thinking about 5-ASA and topical products, we're thinking more mild to moderate symptoms and a low risk for colectomy. So what are mild to moderate symptoms? So this is the True Love and Wit Severity Index. Many of us in academics will use validated indices, but this is something that you could use in clinical practice. So those with mild to moderate disease have six or less stools per day. They do not have large amounts of blood in the stool. They don't have systemic symptoms. They have normal labs. So that is your mild to moderate patient that you'd be targeting with 5-ASAs and topical treatments. If you want to simplify this even further, I don't know where I borrowed this from, but this is something that's very easy to use in practice. Patients in remission have no symptoms. Patients with severe symptoms are severely impaired, so they're housebound, bathroom-bound, or hospitalized, and really the mild to moderate patients are in between. So I think it's a very easy criteria you could use in practice. So what are some additional diagnostic considerations? So if you're starting to use biomarkers more and more, there are some limitations in patients with distal colitis. Routine biomarkers such as the white count, hemoglobin, C-reactive protein, saturation, and albumin are abnormal in anywhere from a quarter to half of patients with ulcerative colitis, but they don't correlate well in patients with more distal colitis. So this is one study that correlates the CRP as 0.24, which is very low correlation, and 0.37 for SED rate. So it's important that you can have a patient who's sitting on the toilet 15 times a day with Proctosigmoiditis, and their biomarkers, their serum biomarkers may be completely normal. So don't be fooled by the labs in patients with distal colitis. What about use of fecal calprotectin? So we're starting to use this more and more, and I would argue that for patients with normal biomarkers despite active disease, this should be your biomarker of choice. So this is one small study that looked at 61 patients with symptomatic UC. 20 of those had ulcerative proctitis, 10 had left-sided, and the rest had extensive colitis. The mean fecal calprotectin was quite high at 600. And you can see here that it seems to be more accurate for left-sided and extensive, but if you really get into the weeds and look at the range in the proctitis patients, you can see that it does go up in proctitis. So I think this is one study showing that you can use calprotectin as a reliable biomarker for distal colitis. This is a different study that's comparing endoscopic activity with SPECT-CT. And the take-home point here is that calprotectin correlates really well in left-sided colitis with the findings on SPECT-CT. I'm not suggesting you should use SPECT-CT for monitoring of distal colitis, but just some further evidence that calprotectin can be useful for monitoring disease activity. So this is the AGA clinical pathway for ulcerative colitis. The low-risk patient, you're typically starting with oral and/or topical 5-ASAs. But remember, if patients do not respond to those early therapies, you see here that you're to escalate to immune suppressant or biologic therapy. There's no disclaimer here that you should avoid using those drugs in patients with distal colitis or proctitis. So if they don't respond, you should be graduating up the treatment pathway to the high-risk colectomy patient. So were published new treatment guidelines for mild to moderate UC, and I'm going to focus on the proctitis patients as well as the Proctosigmoiditis, and then I have one slide that has some special considerations. So proctitis, of course, is involvement of the rectum only. The recommended first-line treatment in patients that are willing to accept topical therapy is mesalamine suppositories. For those that prefer the convenience of oral dosing, we recommend standard dose 2.4 grams of mesalamine or standard dosing of the azo-bonded compounds. For those with an incomplete response, you can either add topical or add oral depending on what you started with, and you could also dose escalate to the higher dose oral mesalamine if needed. And for those with persistent symptoms, it's recommended that you add a rectal steroid. For those with Proctosigmoiditis, that's involvement of rectum and sigmoid only. The recommendation is, again, to start with topical therapy with mesalamine enemas. If patients prefer oral, again, we recommend standard dosing of the mesalamines or azo-bonded 5-ASAs. Incomplete response, again, is the same strategy. You're going to add topical, add oral, or increase dose. And for those with persistent incomplete response, you're going to add a rectal steroid. It's going to typically be a rectal enema as opposed to one of the foams or suppositories. Some special considerations. So in patients with being treated with oral mesalamine, we recommend standard dose over high dose, and we recommend once daily dosing. One of your questions is about the use of in extensive colitis. Of course, oral and topical is better than either alone, so that's important. We do talk about sulfasalazine. We don't use a lot of it anymore, but for patients who have been on it successfully, you can keep them on it, and those that have predominant arthritic symptoms, it can be a really effective therapy. We recommend topical mesalamine over topical steroids. The guidelines didn't make any specific recommendations for probiotics or curcumin, and they also didn't recommend fecal transplant outside of a context of a clinical trial. So this is one of the questions that's important, and I'm glad Brian's here because he may be able to answer about Act 1 and Act 2. So it's important to know that ulcerative proctitis patients were excluded from recent trials of biologics and small molecules. And this is directly from the tofacitinib pivotal trials. Also, looks almost identical with golimumab, adalimumab, and vedolizumab. The one exception is when I looked at the inclusion criteria for infliximab in Act 1 and Act 2, it wasn't specified if ulcerative proctitis was excluded. But I can tell you that for the agents I just mentioned, they were all excluded from the pivotal trial. So we really have little evidence that these are effective in ulcerative proctitis. So to summarize, overall patients with ulcerative proctitis and Proctosigmoiditis have a better prognosis than patients with more extensive ulcerative colitis. Extension does occur in 20 to 30%, so their phenotype can change. Remember that the serum biomarkers may be completely normal despite the presence of severe disease. You want to assess both the patient's current symptoms as well as their prognosis for colectomy when you're deciding on your initial treatment. For mild to moderate ulcerative Proctosigmoiditis, topical therapy is recommended first line for those with mild to moderate symptoms and low risk for colectomy. For those that won't use topical, you can use standard dose oral. Remember that for non-response, you can optimize dosing and or add oral or topical, and you can consider your steroid topicals for those that are still resistant to treatment. And one little bullet here is that Ted Bayless taught me that you can often use a combination of mesalamine and budesonide enemas for really treatment refractory patients who are low risk for colectomy, so that's something you can consider. And importantly, don't undertreat proctitis and Proctosigmoiditis. For those that are failing to respond despite optimization, escalate them up to pyramid to immune suppressants and or biologics. Thank you very much.